Once it says live stream, we'll start. Okay.
Yes, sir.
Yes, Rajana, it is live on YouTube. You can go on.
Yes, sir. Yes, sir.
Sir, Virendra sir, have you come? Have you joined? No problem, Rajana. You can start.
Good evening, sir. Sir, is the screen seen, sir? Now I have shared the screen.
It is a blank. No, not yet. You have to optimize that and then start.
Oh,
Yeah. So anyway, good evening, everybody. Thanks everyone for joining. Till Virendra sir joins, I'll just start the session. See, previously we did some live CMEs and which is there in live section. I mean, live segment of the YouTube. The previous CMEs also you can see. And I request all our alumni, whoever have been to Bettadur in whichever capacity, to take this forward. And then, I and Raju will always be there as your support system. And all my other good friends like Ashish Bhau, Anil Bhau, Virendra Kumar, Kalidas, we all will be there. So we will be moderating in turn. And today, Raju has taken up a very interesting and important topic, ectopic pregnancy, newer terminologies. Many things you told me I was not aware. Certain things you can't call them anymore ectopic or, cornal pregnancy and all that he's going to discuss. So over to you, Raju.
sir. Sir, thank you, sir. Is my screen
No,
seen, sir?
for me, no. No.
Oh. So then what I should do, sir? One
I
second.
don't know what is happening because I have made you co-host. One moment. I'll see what settings I have.
I will share 1 second. Now, sir?
No, 1 minute. Let it come. It is blank. Is there anything on the screen?
Nothing.
Yes, sir. My first slide.
No.
Good evening, JP.
Sir, good evening, sir.
Sir, namaste, sir. Good evening.
Just go to second slide.
Your screen sharing is paused. It is showing, sir. Why? I don't know.
No, this is blank only.
Yeah, it is blank for us.
Unknown caller.
Raju, do one thing. Go
Yes,
there.
sir.
Now it is seen. Now it is seen. Yes.
Now it's visible.
Now, sir?
Yes. Yes, it is visible. Go on, please.
Yes. Namaste and good evening, everyone. I thank you, JP sir, and thank you all the beloved teachers who have joined. On behalf of Bettadur Hospital, I welcome you all, especially the Bettadur cult. It's been long that we have met, and it's a good initiative that we will begin with this, resuming this webinars, the CMEs that we had prior, almost 1.5 years back we had. So today I thought of going ahead with this topic not because that we all know about ectopic and we are very familiar with the diagnosis that we all can make it in ultrasound, and that is the first modality that we have. And also we all are very familiar with how we manage these cases. So here it is just for we all to get to have a discussion. So I will not be the exact person to say that I will be telling you all the right things, but definitely I would request any one of you that you can stop in between and please do correct me so that we are going to have a good interaction between. In between, I will be asking some questions. If possible, try to shout out, or if you can type the message there, I would request Cesarine or someone else to read out the messages. That would be great so that we'll have a kind of interaction. And why I chose this topic was because we all are, there are many terms that we are using on our papers that some have to be abandoned now because the recent consensus based on the American and as well as the Asia group have come with new terminologies which we have to remove and what we have to use so that we all will follow a uniform terminology across and we'll all stay across the globe in one page. So, as we know, before ectopic, we'll try to see what are the basic things that we do when in our daily practice. So, pregnancy is a very warming thing, whenever we get the news that I am UPT positive and she consults you and the when she presents to you and this is what we go ahead. So I will stick with most because pregnancy and early pregnancy, including the NT scan, the answer is always TVS. So you cannot pass on saying that I have done a TAS and I have documented the cardiac activity, I have documented the fetal, the embryo and all. Only it is you have to follow the guideline saying that it is always the dating has to be done with the TVS. So now I will be emphasizing on this, and we all do this basic scans, all of us. So now here is a lady who has presented you and you have treated for her for whatever for subfertility, and now she has conceived. It's a moment of joy, and she has presented you with LMP of so and so. And when you put the probe inside, and this is what you see. And I would ask somebody to describe what you are trying to look here in the TVS, that is in the uterus. So here you are able to appreciate that there is an intrauterine pregnancy, and we all are very familiar to write that it is single live intrauterine pregnancy with a fetal pole inside. And am I right in using these terminologies now? Absolutely no. The answer is no. The answer is here you have to just, I'm able to see a gestation sac with an embryo within and cardiac activity. So now you have to call this as just intrauterine pregnancy with embryo and with cardiac activity. So now uh, this is what the newer terminologies have now. No more using the word viable, no more using the word live. Just you have to mention that there is an embryo or a fetus, and then mention whether there
I
is
think
cardiac.
Raju, your internet connection is unstable, I think.
Sir, no, sir, it is good, sir. It's
No, sir, what happens is this video sometimes get stuck or come slow. I mean, that cannot be avoided in some problems. Something. No problem, Rajana. Go on.
yes,
Can't do
yes.
anything much. Hmm.
Okay. So I still believe there are two things in our practice. One is the ectopic and one is the torsion ovary. These are two emergency situations for us. Definitely ectopic is more life-saving. For these two reasons, I don't want being an obstetrician having an USG as your armamentarium in the unit. Try to make your diagnosis such that you're not going to refer her outside your clinic when she has ended up to you. So there should not be any delay. For that very purpose, we need to be thorough with these things. And always with respect to ectopic, we should always think eccentric that irrespective of her LMP, whenever a lady presents with symptoms in her reproductive age group, think that she might be pregnant and think always ectopic and rule out ectopic. And that is the answer is always with clinical suspicion, do transvaginal sonography and try to correlate after whether you have done your UPT and all. So in this case, I was trying to show you an intrauterine pregnancy with an embryo within with cardiac activity. That would be the proper terminologies. Whether I am right enough to remove my probe at this moment and tell good news saying that, and also show on the screen that where congratulations that you are now pregnant and you have a baby within the uterus. We'll come back to that. So now there are some subtle differences in these two clips. I would like to look into this and try to tell me which is more normal for us and which is an abnormal one. Anybody can answer or shout out because this is where we need to be vigilant in our early pregnancy scans so that we are not going to miss something. So I will say that this is this is the first image, this is the second image. Anything abnormality in the first image or anything abnormality in the second image?
Fibroid complicating. Okay.
Okay, I'll give you one more hint. Both are cases of previous LSCS.
Sir, is the scar in the
Yeah, speak out.
Sir, is the
I'm not
embryo in the second is located at near the scar site? Like, might it be implanted below in the
Yeah, very
second
good.
image, sir?
Yes, though they look very similar, but our initial imaging itself is going to tell us that we have to be. I will come to these later because most of you would have heard me speaking on CSP in my previous lectures. Yes, the cesarean is right that the image, that the clip on the second side is telling there is something abnormal. Though there are embryo within with good cardiac activity, but the location is different, and also we'll look into this case. So now, how many of you want to call this as an ectopic pregnancy now? Or if you want to describe this pregnancy, what do you would call this? I want others other than, I knew that Cesarean will be answering. Cesarean, if anybody wants to type the answers, let them answer so that you can shout out. Anybody with the answers? What is your take on this pregnancy?
So cornual pregnancy or interstitial pregnancy?
Okay, cornual pregnancy or interstitial pregnancy. Very good. So now what do you want to name this pregnancy now?
It is off midline normal intrauterine pregnancies.
The second one?
Off midline intrauterine pregnancy. The second one it looks like interstitial pregnancy.
Okay. What about the third one?
This is intrauterine pregnancy in one horn of the septate uterus.
Bicornuate separate ಅಲ್ಲ.
Okay, I'll take up this later so that we will try to answer these as we go on. So my today's take will be on this paper. I would request you to read because I have shared this paper almost 3 to 4 times in the OBGY group as well as in our groups as well. This came in last 2025 in the early in the first half, where this is the consensus from the American Society, where you have the Society of Radiologists for Ultrasound, and along with them 8 societies came together, like the ACOG, the American Society of Reproductive Medicine, the American Society of Radiologists, and many others, including the Reproductive Society and all. And they came to a consensus with saying that they made a Delphi consensus, which they agreed to 80% of the discussions that they had. I would request all of you, please mute. Only when required, you can unmute and speak.
उठो हम उठो उठो बेटे बिस्मिल्लाह बोलो लाहौल पढ़ो चलो उठो
Requesting everybody to mute themselves. Requesting everybody to mute themselves. Please mute
Thank you.
yourselves.
Yeah, the very discussion for this today's important topic. This topic is going to be on this, because there are many things that we were in vogue using those terminologies. They are trying to give it a different term for this, and they are saying these are the better terminologies to be used. Stop using the other terminologies. I'll try to go across one by one at the time when it is shown up. So you can copy this QR code and download this. It is very, very easily available. When the American comes up, definitely the European also comes out. So it is also, there is another paper on X-ray that is also easily downloadable. Both are on the same boat, saying that many terms have to be avoided. And that is where we need to look into these two papers. X-ray is it's bit older, but definitely that is also a good paper to read. Why do we need this new lexicon where we need to go for the new terminologies? Definitely there was inconsistency across the globe, and many were using different terms for the same pathology or the condition. And also for legal issues, in US they face the problems that we cannot have. So they wanted all of us to use a single terms and be on the same page, and they should be clear and scientifically based. They should be acceptable across the all disciplines and minimize bias and harm to the patients. So now in this Jan 2026, you have a very good paper to read because they have clubbed both the American and the X-ray people regarding the ectopic, the intrauterine and extrauterine ectopic pregnancies, and they have comprehended this. This is a good paper to read because you do have a lot of newer modalities of managing the ectopics as well. Please download this, and if you get time, try to read this. So this is all about. So now, what do you mean by an ectopic pregnancy? We usually think an ectopic is always extrauterine, but now the definition says an ectopic is something where it's implantation in an abnormal location. It could be in the uterus also, and definitely extrauterine is an ectopic. It can be well within the uterus. So we all know from MBBS days that the most common site of the ectopics will be the tubal pregnancies. The rarer ones are the ovarian and very rare ones are the abdominal. Now with the incidence of having an insult to the uterus, now they want to call the incidence of higher rates of cesarean rates. Now the cesarean scar pregnancies are now pushed to saying that they are ectopic pregnancies because the reason is that it comes at a cost. We have to monitor, we have to be very vigilant, and also it comes at a cost of some morbidity most of the times to the mother, if at all we have to continue the pregnancy. So then cervical ectopic pregnancies, now they are previously called as cervical pregnancies, now termed as cervical ectopic, and also off late with the advancement in ERT procedures as well as the endoscopic surgeries, iatrogenic insult to the endometrium or to the endomyometrial junctions, you can also land up having an intramural pregnancies. One thing to add here, it's not always if you look into one intrauterine pregnancies, it's always better to look into the adnexa. That was the importance of my first slide where I tried to show a lady who came to with UPT positive. You saw an intrauterine pregnancy and we removed the probe. That is actually wrong. We need to locate for the adnexa. We should look into the adnexa to look for any pathologies. Most importantly, we have to look for the adnexa just to know where is the corpus luteum and anything beyond that. So now I'm trying to see, that is what I was trying to show you. Now in this case, now after I have located nothing in the uterus, I have moved into the adnexa. I'm trying to show you the ovary on one side. So now what happens is most of us, we try to look into the ovary. That is the wrong thing that we do. Yes, definitely it is important because ovary is the structure where we are easily focused in the adnexa because we all are very familiar doing those in the gynec scans. In our early pregnancy, when you try to locate the ovary, now how many of you think that this is an ectopic pregnancy or is this a lesion well within the ovary? Yeah, this is actually a corpus luteum. But now what is the mistake that we do is that when we have looked into that nexa, we only look at the ovaries and come out. No, we have to go beyond the ovaries because the most common site of ectopic is the tubes. And we know that tubes are not always in the same plane of ovaries. So you have to do your up down movements or you have to go beyond the ovaries to locate if at all you find a tubal ring like structure like this or echogenic lesion which is in close adjacent to the ovaries. So I have located something abnormal here beside the ovary. Her UPT was positive, intrauterine, you don't find any pregnancy or a gestation sac like lesion. But here in the adnexa, beside the ovary, you are finding a tubal ring like structure. So now once I have located that, what is that? I want to name this as ectopic like gestation. I can't say this ectopic pregnancy because I'm not able to see a proper yolk sac as well as an embryo here. But you can call this as an adnexal mass or you can call this as a tubal ring. We'll come to that nomenclatures now. So now once I have done that, what I'm trying to do here, I'm trying to do a sliding sign where I'm trying to place my probe in between the ovary and this tubal ring like structure, and I'm trying to see that they are moving away. When UPT is positive and she has come with this lesion in the adnexa, invariably, most of the times, it is invariably an ectopic pregnancy. So it's an early ectopic pregnancy. So now don't go with colors because that can be misleading just because we know that even a corpus luteum can always show a ring of fire appearance when it is in active mode. So now how many of you want to take the chance over here to say, is this an ectopic or is this an ectopic ring? So I'm trying to show you two cystic lesions in the adnexa. Which of this is an ectopic? Okay. So now there are two cystic lesions. One is showing a bright echogenic ring around, and another is just in comparison with the ovarian echo, but it looks uniform. But inner margins are not well cremated, as not uniform as this one. And now because it is helping us in this lesion, it is helping us with an yolk sac yolk sac. So you will be able to appreciate that this will be more like an ectopic. The reason here is that it has a ring of echogenic ring around because of the trophoblastic tissue. Now this is well within the ovarian echo, and this is more likely to be an corpus luteum. So this is the initial pattern recognition that we should all start looking at the adnexa. At the adnexa, such that we keep looking at the corpus luteum often, then only we'll be able to easily diagnose an ectopic pregnancy. So as I've told you, don't go with the ring of fire. I request those who are muted, please mute yourself. I request all the audience who are there, who have been logged in, to please mute yourself. If required, you can raise your hands, and Shezrin can allow us to speak. Okay, this is what I whenever see this is a case, no, early pregnancy. I have nothing is there in the uterus. I go into the adnexa and I look for the ring-like structures. Now, do you think this is an ectopic? We always find the ovary very easily, but you should go beyond the ovaries. Then only you might look out that you are having a ectopic pregnancy here. Why do I say it as an ectopic pregnancy? Definitely there is an gestational sac which is having an echogenic rim, and also you have a yolk sac, and also you can appreciate there is an embryo within. Is the video played okay, sir? I need one response from you.
Yeah. It is a bit slow, but it is okay.
Okay, thank you, sir. So in this ectopic pregnancy, you are also able to appreciate there is cardiac activity as well. So now what do you find? What do you find the reporting for this? Most of the times we find it as a live ectopic pregnancy. Now that has to be abandoned. You cannot call this ectopic as a live. So so that is what the lexicon is going to tell us, that you can call this as an ectopic pregnancy with an embryo with cardiac activity. So viable ectopic pregnancy, live ectopic pregnancy, these terms have to be abandoned, and make sure that what you see and you just write what you are able to it carries more important weightage that what you have located and what you have seen and what is there within. So you have located an ectopic pregnancy with respect to an embryo within and also an cardiac activity. So I will just brush up the importance here. See, whenever you find an extra ovarian mass separate from the ovary, you can put it as an extra ovarian mass or an adnexal mass. But when you find a good ovary, and if you find a round or oval fluid collection with hyperechoic rim that I showed in one of the clips, that you could call it as a tubal ring or adnexal ring. So definitely when you don't find an intrauterine gestational sac, when the beta HS is positive, always think it is more likely to be an tubal ectopic pregnancy unless otherwise proved. But now what they are asking us to avoid these terminologies, because most of the reports mention this. Even I have seen most of them using these terminologies in webinars, that they look like bagel sign, they look like blob sign, donut sign. Obviously in our unit we have never used this, but definitely more people are using this. They are asking us to stop using this. Some of them even use the Madhur Vada sign and all. So now we have to just tell them whether it is a tubal ring or an adnexal ring or adnexal gestational sac. That carries more better with respect to our reporting. So now what is that? When you don't find an extra ovarian, when no intrauterine pregnancy is seen, extra ovarian mass or a tubal ring, there is high probability there is an ectopic pregnancy. Then how do you differentiate between a corpus luteum and a tubal ring? The first one is the echogenicity. That is what I was trying to show you in the clip. The tubal ring will be more echogenic than the corpus luteum. It's because of the trophoblastic tissue that you have. It appears more echogenic. And now when you look for the color, it is not so discriminatory, because both may show ring of vascularity that we have already shown. Claw sign. So claw sign is where, when sometimes an corpus luteum stands or outpouches from the edges of the ovarian cortex. So that is where you need to definitely make out whether it is an ectopic or an corpus luteum, if you have the ovarian echoes surrounding that lesion up to at least half or more than half, that is when you have to call this as a claw sign. That is one of the signs, because in that the sliding sign will be negative. And what about the sliding sign that I have already shown? When you find a lesion in the adnexa or in vicinity of the ovary, try to do the sliding sign where they move away as you put pressure in between these two. So that is where this supports an ectopic pregnancy. Definitely the location wherever you are finding it. It can be intrauterine or extrauterine. These are very common things that we all come across in our day-to-day practice. A lady who's come here to the OPD and she's there in the waiting hall. Suddenly she feels giddiness. She collapses on the table, and that is where you can suspect that she has missed her periods and that she has come here. And that is when you take her to, instead, you don't want to waste time and you put the probe. Now the answer is always TVS for an ectopic in an emergency. So the answer is always TVS. I repeat this because TVS is going to give you more information than the TAS. So here it is very clear that what I'm trying to show you in the POD, for all those because whenever a presenter is presenting, he has to give his approach of doing the transvaginal sonography. In my case, I keep this is the probe head, where I keep the bladder on this side, and this is going to be the posterior aspect. This is going to be the anterior aspect. Some of them do reverse imaging, so they might get confused whether side is the bladder. But in my imaging, always I keep the bladder on this side, and the POD or the bowel is on this side. So this is in sagittal axis. So that is very easy, because when you find low intensity echoes, and when the uterus is floating with such fluid within the pelvis, it's likely to be a hemoperitoneum, and it's more likely to be a ruptured ectopic, which warrants as an emergency. And you can also find a heterogeneous mass over here, most likely the tube with the clots within. So these are very obvious. We can easily make out. And even here in this case, sometimes you will have to play with your gain settings. If you start increasing the gain, you will be able to feel the clots or the low intensity echoes of the blood much better. And if you try to locate the intensity of the echoes more on the anterior aspect in comparison to the previous, in this case, the blood was more in the POD, not on the anterior aspect of the uterus. But in the adnexa, I was trying to locate the ovary, and beside the ovary, you are able to appreciate that the tube and the gestation, that is the ectopic pregnancy, was noted well within the tube. Less amount of fluid in the surrounding. So intraoperatively, when you try to see, this was a case of ectopic pregnancy with the most common site that we all have. Sometimes it is very difficult to make out where exactly the site of the fallopian or the tubal pregnancy is located. The most common site is ampullary, as we all know, and the definitive diagnosis most of the times will be intraoperative only. So in this case, I will try to show you, this is the axis deviated uterus. So what I'm trying to show you is that in axis deviated uterus, you will try to see the coronal aspect of the endometrium rather than looking as the straight band. You are able to see the coronal aspect as if you take in 3D. So now in this, when I'm trying to locate here, she's UPT positive, and I'm trying to locate something within the endometrial cavity. So now her UPT is positive. She has come with pain abdomen, and you find a lesion which is showing anechogenicity or a ring-like structure within. How many of you want to call this as a pseudo-gestational sac or a gestational sac-like lesion? This was what previously we used to always tell, that it is a pseudo-gestational sac. Now it has to be abandoned. It is no more pseudo-gestational sac. It has to be just called as intracavitary fluid. So that is what cavity fluid, that is the better terminology. They are now emphasizing us to use it. So that is also one of the hint. When you don't find a proper decidualized intrauterine pregnancy, you should always go into the adnexa. In the adnexa, you are able to appreciate the corpus luteum here. And as I go beyond this ovary, you will be able to appreciate there is minimal hemoperitoneum, and also you will be able to appreciate there is a heterogeneous mass which is well within a lobulated surrounding. That is more likely to be a tubal pregnancy which has not yet ruptured, and you don't find hemoperitoneum as you saw in the previous cases. So this Pseudo-gestational sac, the usage has to be abandoned. You just use intracavitary fluid. Then when you look for the adnexa, if just don't look at the ovaries, also trace beyond the ovaries, and you can find such ectopic pregnancies which may be in the verge of expulsion or in the verge of rupture. So intraoperatively, the same case, you are able to appreciate there is less of hemoperitoneum. This can change. The situation can definitely change. In while doing the scan, you would have told that it is an unruptured ectopic pregnancy, but by the time you take to the OT and you put this probe, the scope inside, there might be hemoperitoneum. That can change anytime. Because the behavior of ectopic is such that you will not send a patient when you have diagnosed ectopic to go back home. Only when you find an adnexal tubal mass, which large volume. So in this case, you are able to appreciate that we are doing milking of this the ectopic gestation and the products that were seen in the tube, just to give a chance for this fallopian tube. For this discussion, we will take up later whether to save the tube or not to save the tube. It has its merits and demerits. Simple cases
Raju.
again, sir.
Raju, 1 minute. What is happening is these frames are not continuous. So what you can do is while sharing, just stop sharing, and when you share, no, you have to
I
tick that box, make optimize for videos.
I did that, sir. I did, sir.
Still, what is happening is lot of it's only you are seeing very few frames, so there is no continuity. Just retry once more and then let's go. Anyway, otherwise you can't do much. Go
Shall
on.
I stop sharing now, sir? Once, sir.
Yeah, you already stopped. You go on now. Just tick that box for optimize for videos or something like that.
It is there, sir. I have. Okay. Yes, sir.
ठीक है. Go on.
Is it seen, sir, now?
No, we are seeing only blank. Sorry. ಹೋದ್ಸಲ ಏನ್ ಮಾಡಿದ್ದೆ ಅದು ಬಂದಿದ್ದೆ ಮತ್ತೆ ಬಂತಲ್ಲ.
ಸರ್ ಅದು ಈಗ ಸರ್
ಅಲ್ಲ ನಾವು ಇಟ್ಸ್ ಬ್ಲಾಂಕ್ ಬೋರ್ಡ್ ಕಾಣಿಸ್ತೈತೆ ಏನ್ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ.
One second, sir. Now is it seen, sir?
Share, you are sharing only presentation or you are sharing the full screen?
Now it is full screen, sir.
No.
Raju, minimize and again share. I think it is zoomed up. That's why you are not able to see it.
Yes, sir.
Sorry. Something was visible, now nothing is visible.
Shall I log in again, sir? Then what I
Can't say anything.
Stop sharing and again reshare.
Oh, he did that.
Okay. No.
Sir, try sharing just the presentation and then go to full slide view in the presentation in the software.
Ma'am, please repeat, ma'am.
So when you start share, don't share full screen, just share the presentation, and then in the PowerPoint, go to slideshow.
First exit from the presentation, Raju.
Okay,
Slide share ಇದ್ದದನ್ನ you just change it to the grid view. Share the presentation only.
Now, sir?
1 minute.
No.
No. Same.
Presenter layout is showing blank, sir. I don't know why. Now, sir?
Okay. No.
Or otherwise log out and log in again.
Yeah. Do that. I'll
That
make you
was-
co-host once again. Log out.
So when you are ready, just let us know. Meanwhile, I'll be talking
Yes,
some.
sir. Please.
Yeah. Hi, everybody. We know that diagnosing ectopic pregnancy is very important in our clinical practice. Whenever nowadays patients come exactly the day they miss their period with a kit being positive in their hand. Okay, then most of us will continue accept that test as the test of pregnancy and ask them to come 1 week or 15 days later for confirmation of the pregnancy. But sometimes we may see a patient who is symptomatic or who is very anxious to know whether she's really pregnant or whether she's having ectopic pregnancy, because most of them are educated and they would have read Google, and sometimes suddenly they ask us whether am I having ectopic like that. So in that case, the TVS may not reveal anything. We will be forced to do beta HCG. That 48 hours rule is there. Okay. One thing is very clear. There is something called as doubling time. Okay. So once Raju is ready, till then I'll be speaking. See, what is doubling? Please don't expect exactly the HCG to be doubled in the 48 hours. If it is more than 66% rise over 48 hours, then chance of having a viable pregnancy is there. Even if there is a less than 66%, even majority 49% rise is also acceptable. See, don't expect it to be doubled. If it is 49 to 50% also, still we may be dealing with intrauterine pregnancy. If the ratio between the first value and second value is more than 1.67, the chance of having a ectopic pregnancy is very less. If it is less than 1.67, either you may be dealing with evolving intrauterine pregnancy and ectopic pregnancy probably. And ultimately, diagnosing ectopic pregnancy is dependent on the quality of the machine and the operator and the expertise the operator has. And the famous British gynecologist McFadden, he says, ectopic pregnancy is like a black cat in the dark night. Either you may, it may go unpassed, being unnoticed, or sometimes it may leap on you in the form of the rupture ectopic pregnancy. So ultimately, what is necessary is some illumination is required to diagnose that black cat. So here, illumination is ultrasonologist, like what Raju is telling to tell you. And coming to the lexicon, why it is changed? Because there was a lawsuit in America regarding the use of viable pregnancy, heart motion, all those things. So because of that, and nowadays, whatever we do is patient-centric. To respect the patient emotions, it has been converted into pregnancy failure into concerning for early pregnancy loss. And heartbeat, heart motion, because and at that 6 weeks, heart is not well developed. That's why we have removed that word heart beat or heart motion. Only we talk about cardiac activity. So the change in pregnancy, change in pregnancy terminologies, ectopic pregnancy terminology is because of avoiding the lawsuits and to use the same language throughout the world, and to avoid the emotional anxiety among the patients by confusing words like early pregnancy failure or blighted womb, all those things. So this should always been kept. Don't write pregnancy failure, write for concerning for early pregnancy loss, or you can write that diagnostic of early pregnancy loss. all those things. Raju, are you ready?
Give us some time, sir.
Yeah. So again, we are nowadays we are not using the word like angular pregnancy. I think Raju said it. No more use of cornal pregnancy or angular pregnancy. So most probably we'll be using interstitial pregnancy. I think he's ready. Raju, we
He's
can
ready.
start.
Start, Raju.
Sir, am I audible, sir?
Yeah,
Yes,
yeah.
yes, you are audible. Go on.
This is just a repetition of what Virendra sir was telling. So this lady who presented to us for infertility evaluation very recently in last month on second day, and she was posted for the routine or evaluation for infertility after she gave her blood test and she was asked for 3D scan. And when I put this probe inside, this is what I was able to see. And when I took the proper history, she told though she had bleeding in this cycle was not in comparison to the previous cycle. That is where when you are suspicious of the ectopic, you need to ask the proper history that how was this cycle in comparison to a previous cycle. Maybe they would have shred, but it would be of less quantity because of the area stella that we see in most common in ectopic. And that is what in this lady also we had the same thing on a day 2. And this was a case of almost a tubal abortion with hemoperitoneum. So this can happen because we need to be vigilant when in taking history as well, and we should not miss such emergencies. So though she came for evaluation and she was ended up with having this ectopic pregnancy with the laparoscopy inside. So now this lady is a very interesting history I want to give. This lady, she underwent IVF at us. So she was a known case of bilateral salpingectomy because she had two ectopics in her past histories. And now this time, after her embryos are ready, FAT was the transfer was done, and when UPT came positive, there was nothing was seen in the intrauterine the cavity. So now we asked her to come up after 1 week. So after 5 days, she came saying that she had pain abdomen, and when we did the beta HCG was more than 1,500, but definitely there was nothing was seen. I was not very sure what is there because in again intrauterine nothing was seen, but in the adnexa you were able to appreciate hemoperitoneum. So this is where it really struck us. There is something I was not, because bilateral salpingectomy case when you have transferred and embryo transfer was done, and we expect something to be intrauterine. This case was a case with significant hemoperitoneum here after the IVF transfer. What could be the reason for this? Anybody would take the answer? The answer for this was the stump ectopic. So this is where, when salpingectomy was done, the residual part near the cornal end was actually left, and the embryo has got implanted there, and that is where from this site it started bleeding, and the bleeding was so torrential within few days of her. No, beta HCG was positive, and we had to. This is an entity called as stump ectopic. When you do a tubal clipping as well for your IVF procedure, sometimes make sure that you go very close to the cornal end such that you don't leave any residual or stump fallopian tube. This can happen even in your ART procedures. So this is an interesting case to show that it is a case of stump ectopic. Now, this case, actually, I don't have an ovarian pregnancy. So this case, I took it with permission from Sandesh Kade sir. What they are trying to show you in the ovary, gestational sac as well as the corpus luteum. So this was very interesting to show because ovarian ectopics, though, are very, very rare. And in the intraoperative in laparoscopy view, are able to appreciate an ectopic pregnancy well within the ovary. So this is a case of ovarian pregnancy which fulfilled all the criteria of being well within the ovarian cortex, and also the attachments were normal in this case. And this is how, and also they proved that there was trophoblastic tissue within embryo within. So this is how it fulfilled the criteria for the ectopic pregnancy as well. So why I am trying to post this is because most of the times when we try to see an ectopic pregnancy, it will be very close in vicinity to the ovary. So ultimately, when we are most of the radiologists try to put it as ovarian pregnancy, but it will not be an ovarian pregnancy in majority of the times in our laparoscopy. See, we need to define the corpus luteum as well as the ectopic pregnancy well within the ovarian tissue. Then only this fulfills the criteria that is more likely to be an ectopic pregnancy. So the OCP has to be in one home, that is well within the ovary. So that is where you can make out an ectopic pregnancy. That is ovarian ectopic. So how many of this is what Virendra sir was just talking on this. So how many of you want to place this as an ectopic pregnancy now? So now you are able to appreciate in the transverse view, this echogenic thing is the boundaries of the endometrium. And when I do a 3D, you are able to appreciate that this gestational sac is well within the endometrial cavity boundaries. This is the serosal border. This is the myometrium. This is the serosal border. Previously, we used to think that this could be an corneal ectopic, or we also used to call this as an angular pregnancy. Now, this is no more to be called as an angular pregnancy. This is just an intrauterine pregnancy. So now why? Because this will make the consultants as well as the patients to more, Googling it and all, they will be more anxious to know. The outcomes of this are usually very good when you have a good rim of echogenic endometrial lining around. Now you can also use, you can also use the terminology as intrauterine eccentrically located pregnancy. So that it is still an intrauterine pregnancy. So you can use the word eccentrically located gestational sac completely surrounded by the endometrium. Please avoid the use angular, corneal or eccentric pregnancies as well. These are to be abandoned now. So now this is similar how you locate that in a 2D, where you have an echogenic rim well within the endometrial cavity. This was well within few days of I called her purposely to locate this, and within few days you are able to appreciate that is moving well from this location to the intrauterine place. It might take few weeks, but in this case it is within few days. So this case I had posted for the answer. Most of you have answered it. This is actually, you are able to appreciate this is well within the serosal border, but it is away from the endometrial cavity. So it is an abnormally located pregnancy, which is, it is at the beginning of the interstitial or the intramyometrial segment of the fallopian tube. So now what I'm trying to show you is that this gestation it is located in the intramyometrial segment. There appears a thin band of myometrium between these two. Sometimes you also can find an echogenic line that is also called as the interstitial line sign. It is more specific, though I couldn't make out in this case in 2D. So this is an interstitial pregnancy. Please do stop using the word corneal pregnancy now. There is nothing like corneal ectopic now in literature as of now. Previously, corneal were used in some Mullerian anomalies like in one horn of the rudimentary horn of the unicornate and all. That also has to be abandoned. There is nothing like corneal ectopic now. You have to just say what type it is by looking at the location. It is now interstitial ectopic pregnancy. So this case, what do you think we would have done? It was in the same case in 2D. You are able to appreciate a gestational sac. Now, what do you mean by a gestational sac? A gestational sac is where you have a yolk sac at least. Otherwise, when you don't find a yolk sac within, it is just a gestational sac-like lesion. It is not gestation sac. That terminology has to be changed now. It is nothing like gestational sac. Only when you find an embryo with an yolk sac, or sometimes only an yolk sac, it has to be called as gestational sac. Or you can just name it as intrauterine pregnancy. In this case, it is an interstitial ectopic pregnancy. Over the period, this lady was just managed by letrozole, though there was initially when she presented to us, there was an embryo with cardiac activity, and she was managed totally over the period of almost 1.5 months to 2 months, and this got resolved This is actually, I just wanted to show you the difference between this and this. This is just where the endometrial cavity lining is surrounding this, whereas this is away from the endometrial lining. So this is how an coronal ectopic might look in the intraoperative field, because this is one of the most notorious ones. It can, if it ruptures, it can have catastrophic outcomes like significant hemoperiton, and the patient may be in shock. We need to address it very early. But in our case, we try to counsel her and we try to manage this by letrozole. Eventually, over the period of time, I could call her after 6 months. I could call her after a few months, and the same gestational sac has now got resolved to very minimal now. After this, she was not traceable, but she has not followed up. Maybe that is one of the role of using medical management can help, but it should be under vigilance. So this is a very important entity I want to take, because there is nobody now who has not seen the trend of cesarean scar pregnancy. Every obstetrician might have encountered this, but what is more important is that how do we diagnose it? Here, look at this gestational sac. It is located very in the lower corpus, close to the scar area. So how do you define this? Now, cesarean scar pregnancies, which is what Timor Stitch and his group used to always tell, that it is not an ectopic. Even I used to always present this as not an ectopic. But with the recent consensus, we are now pushing towards, because both the Europeans and the Americans are agreeing that we have to push it towards ectopic, because it comes at a cost, because you need to be more vigilant, and also there are more associated morbidities with this, if at all you want to continue for a viable pregnancy, or what you want to call. This is what they had always had a debate, no, because it is well within the boundaries of uterus. It is not an ectopic, and the CSP can also give a potential to give a live baby which can survive. This is where they would have ended up with having placenta accreta, or maybe the worst of the scenarios, maybe they would have ended up having the hysterectomy. So now the terminologies are changed, because they say it is the X-ray says the potential for significant maternal mortality, and because of its abnormal location, we have to now push it for cesarean scar ectopic pregnancy. So how do they present? We all know this. Most of the times they are asymptomatic. We have to diagnose them easily. Sometimes they may come up with early PV bleed or lower abdominal pain. Never neglect a lower abdominal pain in case of previous LSAs, especially in the first trimester. Look at the location of the location of the pregnancy. So now, how do you define that cesarean scar pregnancy on scan? Look here, what I'm trying to do when I'm trying to locate the the gestational sac or the ectopic pregnancy, what I'm going to call it as, it is there located very close to the scar area in the lower corpus, whereas the upper corpus, that is the cavity, is empty, and the endocervical canal is empty. And this is located in the scar area. Initially, it tries to be triangular. If it moves into the endocavitatory approach, it can get oblongated. And look at the residual myometrial thickness. Usually, if it gets embedded more into the scar area, the residual myometrial thickness keeps on decreasing. That is where, if you find a residual myometrial thickness less than 3 mm, that is supposed to be definitive diagnosis of a cesarean scar pregnancy. Based on the location as well. So now when you look at the trophoblastic tissue, it usually gets attached at that area. That is one of the reason I put up one clip where what is the difference between that. It is, we only look at the pregnancy with respect to the embryo and the cardiac activity, but we fail to look at where the decidua or where the placenta has got attached. So that is where you also find more of vascularity in these cases. These are the sonographic criteria that we need to follow to define this as cesarean scar pregnancy. There are many classifications. This is the most recent one where they try to demarcate between two lines, in the upper border of the endometrial line and the serosal line. If the gestational sac is located more within the endometrial cavity, and if it is crossing less than 50 percentile above the above the endometrial lining into the niche area, it is type 1. If it is well embedded within the niche area and not crossing beyond, not coming into the cavity, it is, or less than 50%, it is type 2. If it is bulging more into the bladder area or the serosa, if it is crossing the serosal line, this is more likely to be type 3. So now what have they emphasized is that I would agree that most of you being endoscopy surgeons, when you try to look into an istomosele, the istomosele, most of the times you don't find the pocket to be in exactly in the midline. You will find those pockets more in one corner, maybe in the right corner or maybe in the left corner, maybe because of the stitch that we take or the defect that we form that is formed more on the angles. So that is where we need to do a transverse sweep as well in your evaluation of your early pregnancy whenever the pregnancy is located in the lower corpus, because the gestational sac might not be seen in the midline. It might be there within the pocket on one lateral angle. That is where they have emphasized that your transverse sweeps are also important because they might get embedded in one of the pockets on the lateral angle. I would ask somebody, please don't annotate on this because we are recording this and this looks ugly. Okay, what I follow is the very simpler one given by the Timor and Stritch, that is type 1 and type 2. He has made it very simplified. You have a scar which is fibrosed. If the decidua has got attached at the scar area, this is type 1, or it is also called as endocavitatory cesarean scar pregnancy. Why is he telling endocavitatory? Is because this pregnancy eventually might lead into the upper corpus, because that is where it is getting its space. As the embryo grows, it grows more onto the cephalad aspect rather than going into the scar area. You do find a good myometrial chunk here, that is the residual myometrial thickness. Whereas in type 2, there is a significant deep niche over here. You have less of residual myometrial thickness, and if the decidua attaches at this plane, it gets more embedded within the scar area. And these pregnancies, if you diagnose early, you will be able to look into the more complications of this pregnancy, is definitely more for the placenta accreta. Sometimes they may even go for rupture uterus. So I'll skip this because that is I want to emphasize on this on basic pathophysiology, what happens in cesarean scar pregnancy. As we all know, the trophoblastic invasion starts from this arcuate and radial vessels, and they form the basal and spiral arteries. That is when a normally implanted pregnancy will draw the blood from these arteries, which are more less resistant. They are more less resistant, and the trophoblastic invasion helps in the proper development as well as the encroachment of this placenta. Suppose you have a niche and you don't find the proper trophoblastic invasion of the basal and spiral arteries, then definitely they'll go invade into the arcuate and radial arteries. These vessels are high resistant vessels. That is when, whenever somebody says that it was an early pregnancy, I took her for DNC and suddenly she started pouring, though it was just 7 weeks or 8 weeks. They encountered torrential bleed. What would be the reason? The reason is they have encountered hitting this radial and arcuate vessels, which are high resistant vessels, and eventually they are non-compressible vessels. They eventually bleed a lot. So these are the situations when you find somebody has taken up for DNC when they have not diagnosed CSP properly. This is the complication they might end up, because many cases we have seen in our center being referred because they had encountered torrential bleed, and you are able to appreciate significant hematoma at the scar area. The upper corpus, though it has hematoma, but the more the clots are more in the scar area. So definitely your imaging plays a very important role, so that you are going to guide the surgeon that it is a CSP or a cesarean scar ectopic pregnancy and needs a better care or a better intervention rather than doing it with low resource setting. So we all know the complications, what can happen, and the placenta accreta spectrum is one complication that we have to think of, and the associated mortality and morbidity also is very high on CSPs. This is a very good video for all those who want to just watch it, because this is trying to explain us that how we can easily miss a cesarean scar pregnancy.
Well, this is a slide that was shared with me by Dr. Timor again, and it shows you what I now think you would look at and you say, that gestational sac at 6 weeks is too low in the uterus. You can see the decidua implanted in the niche. This is definitely a niche pregnancy, right? But the patient says, it's taken me a long time to conceive this pregnancy. I don't want to give up. I feel fine. I'm not having any bleeding. Can't you see me next week? So she comes back at 7 weeks. And what do you see? Well, the embryo is growing into the gestational sac. It has a good heartbeat. Things are moving into the uterus. And she says, well, look, things are looking better. Can I come back at 9 weeks? So you have her come back at 9 weeks. And the embryo is growing even further into the uterus. It looks really normal, has a great heartbeat. Should we be relieved? Should we feel that, whew, escape that? Anybody feel okay about this? Well, we can't, right? We need to still be worried because where's the decidua? The decidua is still in the cesarean scar, and the placental vessels are stayed there in this patient as it increased risk for placenta accreta spectrum and the outcomes that I shared with you previously.
So the importance is that as we delay in diagnosis, especially if the lady with the previous LSS, if she is educated, the prior surgeon who has done the surgery for her, educate her such that if she misses her period, she should definitely have a good interval before she gets pregnant. And if she misses her period such that she reports early, we can diagnose CSPs on early. If she has crossed more than 9 weeks or 10 weeks, sometimes when the decidua has got attached only on the superficial part, and if the embryo grows into the endocavitatory form, then we might miss the cesarean scar pregnancies. And these cesarean scar pregnancies, which are missed with the placenta being attached at that area, are going out to be your placenta accretas later. So we don't want surprises like this on table because that is where, this would have been a missed cesarean scar pregnancy. So the enough evidence to say that it was again Timor who gave that literature saying that they share the same placenta tissue. Now, this was the case that I posted in the second clip. Cesarean rightly diagnosed it because though the placenta is looking on the posterior aspect, it has got anchored at the level of scar area. Now, why do you think it is so? It is because it is at one of the angles of the scar. It is not exactly at the midline. When you move your probe towards one side, this placenta is getting attached. So this is on one side. When I go towards the other side, this placenta has got anchored at the level of scar. And this is where it is a cesarean scar pregnancy. You might miss it saying that it is an intrauterine pregnancy. So this case, it was almost up to 8 weeks. And this was actually managed by JP sir in the transvaginal approach. This is a short video to show that we can definitely manage such cases of scar ectopics by vaginal approach as well. Once we have separated the vesicovaginal fascia, exactly the scar area, giving the sharp cuts and removing the trophoblastic tissue or all the entire gestational products there. And again, once you have the good point about this approach is that it can be done in a low resource setting as well, and those who can do hysterectomies can definitely take up this. And also at the same setting, you can redefine the cesarean scar defect and do the closure of that istomosal defect. So this is another video by Dr. Ashish sir, where he is also taking the same the principles as I shown in the previous case, where once you have separated the vesicovaginal fascia with sharp dissections, and you will be able to appreciate the trophoblastic tissue which is there at the bluish or the brownish hue that you see at the scar area. So this can be managed definitely by the vaginal approach. So in the same sitting, you can also do the defect repair, that is the istomosal repair after sharpening out the edges. So this is a case of that cesarean scar ectopics can also be managed by the vaginal approach. Most of the cases can, in early pregnancy, can be approached by your hysteroscopy approach also. In this case also, we were able to do it in hysteroscope without using your current as well. With your loop, cold loop, you can just evacuate. Most of the, we think that it might bleed. It depends again. We'll be able to tackle it at the same time, but most of the times in early pregnancy, the trophoblastic tissue can be easily be detachable. So laparoscopy also definitely plays one of the gold standard, the better approaches when you find a lot of adhesions anteriorly, and if in ultrasound you are able to make out adhesions, this approach would be more better where you have an advanced ectopic pregnancy and if you have taken the modality for surgery, and this is where once you have gone for laparoscopy, and these are the steps that most of us all are familiar with, after separation of the bladder and injecting vasopressin, and also making the evacuation of the cesarean scar pregnancy that is there, and making um, apart from precise incisions, sharpening the edges and taking the approach of repairing the cesarean scar defect in the same sitting. So this is a case of cesarean scar ectopic that was again dealt. This was dealt by laparoscope. So definitely in vaginal approach, you might find difficult in such cases when the uterus is plastered to the anterior abdominal wall. So in TVS also you can make out these adhesions by doing the abdominal pull test. And if you find that it is very badly adhered, you can approach this route. Okay. So CSP, I'm not able to play. Okay. So this case I want to discuss where, this lady who presented to us at 6 weeks of gestation, and this is the initial scan that I could see that the upper corpus is empty. Look at the decidua. It has got attached or anchored at the level of previous scar area. And this was diagnosed to be a cesarean scar pregnancy. And this lady was so adamant that she told, no, I am going to, it's like the video that I played earlier. No, I just want to continue this pregnancy at any cost. Even after counseling to their attenders as well as taking a lot of grave risks, she told that I will go ahead with the pregnancy. I eventually monitored her almost within few weeks because she was very closely accessible to us. We are most of the Bettadur family, everybody knows about it. So now in the initial period at 12 weeks when I was doing that the NT scan, I was able to make out that this placenta is more likely to getting into more of lacunae within, and it was likely to go into placenta accreta because it was more into the niche variety rather than on the scar variety. So after I did that NT scan, I could able to appreciate there are more lacunae in this placenta, and there was more bulge of this gestational sac or the ectopic pregnancy into the more into the bladder area. And significant vascularity as well. So these areas, what you are trying to find out at the scar, in the placenta are all initial features of your placenta accreta spectrum. Even after now, I only had thought that she will end up maybe having a viable pregnancy, but that will be at cost of having a placenta accreta. But the situation worsened when she was working. She collapsed and she was immediately shifted to the OT just to look at the intraoperative finding here. So this was she was such in a bad state of hypovolemic shock that once we put the trocar, this was the picture. Sorry. So what would be the plan of action when you would have seen such catastrophe? It's not always that we need to may always go with the laparoscope approach only. It depends on the resource setting, on the expertise of the surgeon. Here we have taken up laparoscopy approach. In this case, it was JP sir here. And what I was trying to show you initial part was we are able to see the ruptured area of the uterus. The gestational sac was seen, significant hemoperitum. The upper corpus has gone below. We couldn't localize it initially after significant suctioning. And once we instilled the vasopressin, and we went ahead with bilateral uterine artery ligations. It was a 16-weeker. It was difficult with the anatomy and the engorged vessels over here. And this was where this was the first on the left side. The left uterine was tackled. And similarly, the same steps were repeated to localize on the right side, and the right uterine was tackled. So now after that, so this was the right uterine. So with some bladder dissections, and this was the 16-weeker fetus with the uterine rupture. So at the same the scar, the ectopic pregnancy was now evacuated out after the bladder dissection, and this was the fetus that we removed. So now what would be the other thought, most of you would have thought that we would have gone for hysterectomy at this place. Yes, that could have been one of the approaches, but we thought of restoring the uterus, where we went ahead with what you can see of late when in placenta accreta spectrum, the wedge resection that we have done in the similar manner in this pregnancy, we have done it, and with significant resections of the myometrial planes where the placenta was densely adhered, it was removed, and the edges were freshened up, and like any other ectopic, it was managed with the barb sutures, managed with the repair of the defect. So this was a very interesting case. Now we did this way back in 2024, I suppose, 2 years from now, and eventually she did well. We lost her contact. I just wanted to see her, how she is doing after such a catastrophic event, and and I wanted to actually look how the uterus is now after such a uh, uh, I could say a fantastic surgery, and she went well. And somehow I got, after 6 months, I called her, and this is the post. After 6 months, I could see that the uterus is having almost a normal appearance at the fibrosis at the scar area, but and absolutely no adhesions in the anterior wall. So she was doing good with her menstrual cycle as well. And one more update is that this lady, after 1 year now, she has got pregnant. I have recently done her NT scan, and now now she has reached almost 20 weeks. And recently, I have done a circlage for her because her cervix is now incompetent. So what is the importance I want to emphasize here is that whenever you do whenever you do an early pregnancy scan, even when you are looking into an NT scan, always do a TVS and always locate the scar area. Do you think this is a cesarean scar pregnancy here? This is the scar area and this is the placenta. This is today. Today, just to emphasize the importance of doing TVS. If I do TAS, I usually don't. I look at this area, and or it is not well visualized because of fibrosis. And we, even if the placenta is in the posterior or in the lateral angle aspect, we miss it out. But here, this is not a scar. This is not a cesarean scar pregnancy, because you do find good myometrial chunk from the lower segment, which is not formed yet, but definitely it is well away from the scar area. So this is the importance to look. Always keep looking at the scar in a previous scarred uterus. In this pregnancy, make sure that the trophoblastic tissue or the placenta is well away from the scar. So what is the diagnosis in this case? This is the cervix. This is the corpus. This is not a scarred uterus. So what I'm trying to show you is upper corpus is empty. There is closed internal os, and this pregnancy is well within the boundaries of the cervical canal. So this is an early cervical ectopic pregnancy. So what are the features to say that it is a cervical ectopic pregnancy? One is you should have an empty corpus and also an closed internal os and the trophoblastic tissue well within the cervical canal, not include, if at all it is a previous scar uterus, this decidua, you should not be anchored at the scar area. You can have a cesarean scar pregnancy which is moving into the cervical canal as well. Those are very rare though. So this is a cervical pregnancy. This is a very important sign that we can always use this in your practice, where when you are confused, to say that if I want to ask you whether it is a cervical pregnancy. Look here. You usually don't find initial PV bleed whenever you have a proper cervical pregnancy, but when you have an ongoing expulsion, if you want to differentiate from a cervical pregnancy, try to do this sliding test, where when you put the probe pressure, the gestational sac moves or gets elongated with the probe pressure. So that is where you will be able to. This is called a sliding sign in differentiating between a ongoing process of abortion or a cervical pregnancy. And also you look, the internal os is open. So this is where to show that we can definitely look for a differentiating feature between a cervical and a scar pregnancy. This can also be applied in your ongoing failure of pregnancy or a pregnancy loss, where in a previous scarred area, this was told to be a cesarean scar pregnancy with heavy bleed. When I could do this sliding test, I was able to appreciate that this is not a scar because it was not, the placenta was not anchored here. When I could do the sliding test, this gestational sac is getting elongated. So eventually she expelled, it was in the process of expulsion. So even when you have a cesarean scar area, when you find such difficulties, you can use the sliding test to just to differentiate what type of pregnancy it is. So this was my first slide. This was my first slide where I was trying to show you that I was happy looking for an intrauterine pregnancy. I removed the, I thought that we will remove the probe and tell the mother that about the good news that she has, that she is having an intrauterine pregnancy with an embryo with a cardiac activity. We are not going to stop here. Now we have learned that we have to always look for the adnexa. And once you start looking into the adnexa, in this case, you will be able to appreciate as a go towards the right side at the level of fundus. We could see another gestation sac like lesion, and that was then ectopic pregnancy. It was an heterotopic pregnancy. So don't be always happy that once you locate the pregnancy within the uterus and just come out. Always look thoroughly your adnexa, and this was in closely abutting onto the serosal surface here, just maybe on the initial part of the fallopian tube. Why am I telling it is on top part of the fallopian, the extrauterine part is because the serosal borders were well made out in majority of the angles. So the good myometrial counter was seen from the intrauterine pregnancy. So in laparoscopy, this turned out to be a early ischemic heterotopic pregnancy. So she was around 7 weeks of gestation, and definitely laparoscopy plays a very gold standard in such heterotopic pregnancies. And in this case, we did salpingotomy. We gave a niche at the most lateral aspect and just evacuated the products, and we left it. So eventually she did very good, and she also delivered. So this is where the importance of looking into the adnexa plays a very important role when you find an intrauterine pregnancy. It's always very important that you look into the adnexa thoroughly. So what do you call this? This is a Mullerian anomaly. Okay, we actually this is a septate uterus. Because why I call this septate uterus? Because it is the indentation of the endometrium, but there is no indentation of the serosa. So now previously they used to call this as a coronal pregnancy, because it was told that one of the definition of coronal pregnancy is in one of the horns in a Mullerian anomalous. Now they have removed that. Now you have to just tell it what type of Mullerian anomaly and where is this pregnancy. Now in this case I have to tell it as the pregnancy or the pregnancy or the gestation sac is located in the right horn or the left horn of the right horn or left horn of the Mullerian defect. For example, describe this as gestation is located within the uterus of the Mullerian anomaly. So the right horn or the left horn of the septate uterus. Similarly, call it as unicornate uterus, or even if it is bicornate, you have to mention the Mullerian anomaly and then mention on which horn it is. So UPT negative, but you find this picture in the pelvis. What could be the reason? Yes, kids sometimes play foul. You have to repeat with another kid, or maybe do you have time for sending it for beta HCG here? She has presented with pain abdomen. Now you all know that we will not rely on LMP always. So this is one of the most differential diagnosis can be there, because significant hemoperitoneuria with hypovolemic shock with UPT negative with no obvious heterogeneous mass. I am sorry that I couldn't show that in the I missed that showing in the USG. This you can end up having sometimes like the corpus luteal cyst hemorrhage. So there can happen a significant hemorrhage from the corpus luteal cyst hemorrhage as well. So this was a case of corpus luteal cyst hemorrhage. So that was one of the differential. I will just brush up with few things. If there is beta HCG positive locate the gestational sac. If it is well within the uterine cavity, you think it has intrauterine pregnancy and go ahead with the. And if it is no, then you look in the adnexa mass, look for the tubal ring sign or the abnormal uterine locations like the interstitial part or the scar area. And if it is probable or a definitive ectopic pregnancy, it can be, you characterize whether it is tubal, ovarian, or interstitial, because we all easily can find this out. Okay, now if it is no, then you can think of an unknown location that is very rare, but we need to follow up with those with beta HCG. And also always, when even if you get an intrauterine gestational sac, look for heterotropic pregnancies. So what are the new definitions? It's not always extrauterine. It can be uterine ectopic pregnancies as well. Avoid these terms like cesarean scar now to be told as cesarean ectopic, cervical as ectopic, cornual has to be abandoned. Make it look whether it is an interstitial ectopic pregnancy. No uses of words like live, living, or viable ectopic. It is just to be ectopic pregnancy with cardiac activity. There are many terminologies to be avoided. Just for completion's sake, I will just highlight the few ones. Stop using the pseudo sac. You keep it as intracavitary fluid. You use cardiac activity as the word and describe the Mullerian defect, because that is where you should stop using the word the cornual ectopics and all. So this was all about ectopics. This is a very important paper that you have. I thank JP sir for giving me this opportunity and all those who have logged in. Thank you very much, sir. I'm sorry for the glitches that we had.
Thank you, Raju. Nice presentation. I request Virendra sir to give comments before taking any questions.
Sir, I have one question for the audience, sir. If anybody can answer this, can I share one case, sir?
Yes. Yes, Raju.
Yes, sir. Sir, here is a lady who was present to us saying that it is a case of ruptured ectopic pregnancy. And by her LMP, she had just missed her periods by some 1 week, around she was 4 weeks, 6 days. And when I did the scan, there was hemoperitoneum, but it was not very significant. And definitely, I will not rely on the LMP now. Now, what happened when I saw there is hemoperitoneum in the POD, and definitely, and because her UPT was positive, I cannot rely totally on her LMP. So, and it was at night. It was around 11 o'clock. So now, even that time, even if I send for beta HCG, it will take a lot of time. But definitely for the preoperative profile, I sent for CBC. In CBC, the platelets turned out to be 30,000. So now, what do you think I would do with this case, whether it is an ectopic or whether I should wait for this case? Many of those know this. I don't want Anita ma'am and others to answer. Somebody like others can take up this case. What history should I have asked in that lady who presented with UPT positive and hemoperitoneum? It was not very significant, but only in the POD. But the platelets are just 30,000.
Think I should ask for history of hemimenstrual bleeding, because these are maybe the case of ITP.
Yes, sir. She had no bleeding, sir. But her history, I'll give you one more hint, sir. She presented with history of fever 5 days back with myalgia.
Okay. Dengue illness?
Yes, sir.
Viral illness. Okay.
Yeah, yes, sir. Yeah, it is third space loss. I called JP sir at that moment when I got the CBC, and sir told, no, you stop it. You send her for dengue this thing, and it turned out to be positive in the morning. So eventually she was managed conservatively. Then after the 2 weeks when we called her, we could see a small intrauterine gestational sac, and eventually she continued with the pregnancy. Thank you, sir.
Even family list is also important. When I was a lecturer, I had the opportunity to witness a patient who has Glanzmann's disease. It is a
yes, sir.
receptor disorder wherein her sister also had hemoperitoneum, and mistakenly she was opened up. In those days, laparoscopy was not readily available. Unfortunately, patient had then underwent laparotomy. So what I want to say is, not only ectopic, we should keep in mind ITP or dengue illness or some rare platelet disorders before diagnosing all
Yes, sir.
hemoperitoneum as a case of
They are rare, sir, but definitely, sir, we
yeah,
have
we
to.
should keep in mind. As
Yes,
a
sir.
clinicians, we should keep in mind. And to summarize, Raj has beautifully explained the terminologies change, which is very much essential. Otherwise, we keep outdated. And we should be proficient in transvaginal sonogram because that is the hallmark of all gynecologists. Definitely, if you send any case to radiologist, they will not do transvaginal scan and end up missing so many cases. All of us should be proficient in transvaginal sonogram. That is one important. And whenever you are dealing with any pregnant woman, always be suspicious of ectopic, more so cesarean scar pregnancy, because the rate of cesarean section is definitely increasing.
Yes, sir.
And the one more word you should not use is pregnancy failure.
Yes, sir.
Okay, so it
Early
amounts
pregnancy.
to because pregnancy is always an emotional thing and a matter of joy for many women in India. So if you label or type in your report as pregnancy failure, it amounts to some kind of guilt. That is the reason they have avoided using the word failure. You write either concerning early pregnancy loss, or
Yes, sir.
if you say, you write that diagnostic of early pregnancy loss. Please don't write as pregnancy failure, and
Yes, sir.
don't write blighted womb. So definitely not accepted. And
Yes, sir.
always
Blighted home is outdated, sir. Yes, sir.
yeah, definitely outdated. And whenever you are
Even
doubtful of
miscarriage, sir.
ongoing pregnancy, please use beta HCG. And as I told, doubling is definitely not doubling. Okay, we don't expect it doubling. So many patients have been given unnecessarily some abortifacient drugs, thinking that it is a failed pregnancy. So always beware. There is something called a discriminatory zone of SCG. So
Yes, sir.
you have to see a intrauterine gestation sac with embryo if the value is more than 3,500. It differs from one institute to another institute. When I was postgraduate, I don't know whether still it is being carried in Williams. It was written as 1,500. If it is 1,500 by TVS, you must be able to diagnose
Yes,
intrauterine pregnancy. But this is no longer true because it is the
When
discriminatory zone to see a intrauterine sac maybe anywhere between 1,500 to 3,500. It depends on what cutoffs. Till maybe patient may require serial scans. Don't unnecessarily label it as early pregnancy loss or pregnancy failure in patient's terminology. And that is, everybody's heard about Kadar's criteria, wherein you expect at least more than 66% rise on 48 hours. 66%, not exactly
Yes.
doubling.
Yes,
And
sir.
if more than 66% chance of having a intrauterine pregnancy is
Intrauterine
very
pregnancy
high.
is more.
And even in ectopic pregnancies, doubling can occur in 15% of the cases. So this you should remember even in ectopic pregnancy. So doubling is not really necessary. High index of suspicion and serial scans. And in suspected cases, doing a negative laparoscopy is not a sin.
Yes,
Suppose
sir.
you are in doubt that hemoperitoneum, and the role of medical management is for highly motivated patients who are ready for compliance and follow-up and in selected criteria. The use of medical management boils down to very selected patients, and my experience with medical management is not very good. Whomever I taken for nearly 60 to 70% of the patients ended up in another surgical procedure. Thank you,
Yes.
Raju, for highlighting
Thank
so many things.